Let me first share my conflicts. I try to collect conflicts because that's how we can get funding for research. So my task this afternoon, is to talk to you about the minimally invasive approach to esophagectomy. I think the first thing to do is to define who needs or who ought to be considered as a patient for esophagectomy, and I just got this copy from the NCCN guidelines, which pretty much shows that patients without metastatic disease who have esophageal cancer, at least the middle or lower third of the esophagus, squamous or adeno, at most stages should be considered for esophagectomy, most of them in conjunction with adjuvant or neoadjuvant therapy. So it's important to consider all these patients and not just to send them to a medical and a radiation oncologist. What are the surgical approaches? There have been multiple approaches. There is the three-hole, there is the transhiatal, there is the Ivor-Lewis, and there is esophagogastrectomy. The type of operation is often center or operator dependent, and it can be open or minimally invasive. Some of the approaches also depend on the type of disease you're dealing and on the conduit. Really, the various surgical approaches pretty much only vary by the place where you put the anastomosis, whether it be in the neck, in the chest, or lower down in the chest. Now, upper third tumors, if they are well below the upper esophageal sphincter, and or patients with high-grade dysplasia need to have their entire or most of their esophagus removed. If the cancer is really involving the upper esophageal sphincter, they best be treated with chemoradiation definitively. Middle third, probably a three-hole so you can get a good margin. And distal third, that's where various groups disagree and either do an Ivor-Lewis type or three-hole. Choice of conduit. The stomach is the most common conduit. As someone said, it's very, very reliable. It's very durable. Mark Oranger used to say that you can stomp on it, jump on it, and